So what can we do about this? When we look at modifiable CVD risk factors, because there are some things we can't change, but there are other things that we can control in our patients. And in fact, traditional cardiovascular risk factors still matter. So when you look at traditional cardiovascular risk factors in people living with HIV and AIDS, several studies that have been conducted in the US, including the WISE and MAX, which are the cohorts with HIV positives and negatives, and the SUN study, which had all HIV infected patients, we see that in WISE and MAX, 40% of people have high blood pressure, 21% have diabetes, and we have high smoking rates, 37% were current smokers. In MAX, again, the smoking rates were high, and in fact, high smoking rates were associated with coronary artery calcium, plaque, and stenosis. In the SUN study, where 43% of patients were current smokers, current smoking was associated with higher levels of a marker of inflammation and immune activation, soluble CD14, and that was independent of their viral load or CD4 cell count. So even if you were virologically suppressed, smoking cigarettes was associated with higher levels of inflammation and immune activation. And studies done in Cameroon looking at HIV and hypertension, and here they looked at different regimens, and you see that across the board, looking at the NRTI portion of the regimen, D4T, ZDV, which is AZT, 3TC, tenofovir or FTC, and looking at NNRTI regimens, efavirenz versus nifurapine, there was about a 40% prevalence of hypertension, regardless of NRTI, and slight differences in NRTI in prevalence of hypertension with respect to NNRTIs, where people with efavirenz had somewhat higher levels prevalence of hypertension than people with nifurapine, but it did not reach statistically significant differences. So prevalence of hypertension was pretty high. And when they looked at dyslipidemia, and black is normal lipid levels and the white is abnormal lipid levels, they found that in terms of proportion of patients from 0 to 100%, 29.8, almost 1/3 of them had high total cholesterol levels. Just about half of them had high, get my pointer right, triglyceride levels. 18% had low HDL, which we know is a risk factor for heart disease. 1/3 had high LDL, and there was also significant prevalence of abnormal total cholesterol to HDL ratios, and 70% had some abnormality in their lipid levels. And that's quite significant. But the good news is we can control these. And so a study by David Hanna out at Albert Einstein and in the WISE study looked at trends in hypertension treatment and control. And at that point, we were using 140/90 as our marker of hypertension. That has changed recently. But among WISE participants by HIV serostatus, where the lighter colored line is HIV positive and the dark line HIV negative, so the black line represents the negatives. When we look of percent of hypertensives who were on treatment, you see that the HIV positives were actually doing better. 81% of them were on treatment compared to 73% of the negatives. And when you look at control, similarly, 59% of the HIV positives had achieved control of their blood pressure compared with 46% of the negatives. They did the same thing with diabetes and saw here that the positives and negatives had about the same percentage of diabetics being on treatment. Still not great, 60-something%, but the HIV infected patients were not doing any worse. And in fact, their control was somewhat better. There is a large trial that is international trial that's being run by the AIDS Clinical Trials Group, the REPRIEVE trial. It's a randomized double-blind placebo-controlled trial that looks at the effect of pitavastatin on cardiovascular events in treated HIV. And pitavastatin was chosen because it did not interact with any of the antiretrovirals. Its goal is to enroll over 6,000 patients, all of whom are virologically suppressed and have CD4 cell counts over 100. It's going to run over 6 years. And the primary endpoint is having had a major cardiovascular event. And what this study aims to find out is if we can improve outcomes in people with HIV by starting statins, even when they have cardiovascular risk scores that are lower than the cutoff we would usually use in clinical practice. So is it beneficial to people with HIV to start them on a statin, even if they would not otherwise meet criteria for statin treatment based on traditional cardiovascular risk factors? So that study is ongoing. I think they're over 50% enrolled, but we don't have any data from it yet.